I've asked Dee when we get started to give me a really awesome signal. Was that it? Okay, there we go. So we're call this meeting to order. This is the first e-bunk meeting of the new year. It's Friday, February 21st, 2020, and it is a few minutes after 9 a.m. I'd like to can I just make sure I'm hitting all the bases, because I believe I have to pass it over to Sedgwick County Chairman Pete Meissner, as they have a distinctive way of calling the roll. So the chair recognizes co-chair Pete Meissner.
Okay. Thank you, Mayor, and good morning to City Council members and fellow commissioners. I appreciate the chance that we get together. I think it's good that we continue to show the progress. I think the citizens of the community like to know and like to see and like to witness how we have our mutual efforts to make the community better. So thank you for honoring us. And yes, at the county commission, to do an official meeting, we have to take a roll call for the record. So we will, Madam Clerk, right? She's got it, so she will take the roll.
Commissioner O'Donnell?
Present.
Commissioner Dennis?
Present.
Commissioner Howell?
Present.
Commissioner Cruz? Present. Chairman Meissner?
Present. And with that, all back to you, Mayor. Thank you.
Excellent. Well, thank you. I was hoping I'd be a little more entertaining, that you had to stand up and do something more official for it, but we'll accept it. So the purpose of this meeting is for the city and county to get an update on the integrated care team, as well as the Mental Health and Substance Abuse Coalition. For the first item of business, the chair will recognize a report on the city-county integrated care team. And I don't have in my notes who is delivering that report, so I apologize.
I'm going to see Dr. Gallagher and who else, Lacey? And Chief Snow. They're coming up.
Whole family.
Oh, we get a family. Okay. These are members of the team. They'll introduce themselves.
Thank you all for being here, and good morning.
Yeah, good morning, Mr. Mayor. Good morning, Council or Commissioner Dennis, and good morning, all the members of the City Council and also the County Commission. Here today with me are the other public safety entities between Sedgwick County and the City of Wichita that have collaborated to formulate this integrated care team. So I'd like to introduce to you, first of all, Dr. Gallagher. He actually representing the Office of Medical Directors. I'd also like to introduce Chief Ramsey with the Wichita Police Department. Frody and Slip. Yeah, and I need to recruit you. And each one of them also have some storytellers that are going to provide some personal experiences for you today. And also from ComCare is Joan. All right. Yeah. So I will let Dr. Gallagher introduce his storyteller for you, and then each one of those respectively before we begin.
Thanks, Chief. I think we all wanted to be a firefighter at some point, so he's probably not too unhappy. So a portion of this, once we get through the introductory statements and some of the data, is some stories that we wanted you to hear from the front line, from the people who are out there serving the community. So we have each brought a respective member from our genre to tell one of those stories. So from EMS, I have paramedic Brian Shasted with us. He'll be telling us a story that I think is pretty powerful about how the medical component of this program really added to it.
Good morning. With me is Officer Richard Turner, who has been instrumental in this team and getting it up and running well.
And then representing the clinician on the team is Sarah Slifer from ComCare.
So this morning, what we wanted to do is to provide you a little bit of some updates. Integrated care team was formulated, actually began doing some work with both internal and external stakeholders back in 2015. And at that time, we, as public safety agencies, thought that maybe we needed to evaluate the services that we were providing and the efficiencies and the resources that we had. So at that time, we all got together and we sat in a room and we began to evaluate and analyze the services that we were providing. Our guiding principle at that time was simply no degradation in services, and also to see what areas we could improve on as far as efficiencies. It took us about 2 years to gather enough data to actually make some very informed decisions that benefited the community. That was back in 2017. Dr. Gallagher took the lead. He worked with both the internal and external stakeholders. We changed a process that we were currently doing over with emergency communications, and that was kind of the kickoff program. Had a lot of success from that program. The Wichita Fire Department was probably the one that drove the bus on that because it affected us the most at the time. Our medical calls were escalating at a rate in which we could no longer service them with the current resources that we had. Since the implementation of that process, then what's more from that is the integrated care team. Integrated care team actually was formulated in July 31st of 2017, and it was formulated by a collaboration of all the public safety entities. In the public safety, the integrated care team is comprised of 3 different entities to make it work. At the time, like I said, if you backed up to 2015 when we first got together, it was a prioritization to address the service that we provided on what we called high-frequency, low-risk type of calls. We changed the process with emergency communications. That helped the Wichita Fire Department, but there was still a community need out there for homeless, for mental health types of things. So as we continued our discussions and continued our analyzations of our current processes and the resources that we had, we formulated this team called the Integrated Care Team. To make this team work, it is directed towards mental health. To make it work, it takes 3 components. It takes a qualified mental health worker, which currently is being served by ComCare. It takes a law enforcement portion of it, and it takes a paramedic. And it has to have all 3 for it to be successful. What we're here today to do is to tell you we've ran 2 different pilot programs. One started in July and ended at the end of October, and then we're currently in a second pilot program at this time. So what we're here to do is to provide you the data from those 2 programs. And with that, then I'll turn it over to the next speaker.
So just for familiarity, you may have seen this out in the community. This is the integrated care team vehicle. Special thanks to Chief Snow and the Wichita Fire Department for enabling us to have the equipment necessary to do this. But if you see them out serving the community, this is their flagship. So I have the distinct honor of taking you through the numbers. So this is not designed to be a real detailed overview, but to give you a feeling for what the breakdowns of the impact that we've been seeing, the categorizations that we've been able to find, and some understanding of the costs and value add that we've been able to do. So from the first day of the pilot until current, we have encountered we have responded to 256 calls. And the colors break those down into general categories of disposition or what the result of that call was. So expressed as a pie chart, you can see that about just over 20% when we responded, there was nothing to be found. It was a dry run, there was no patient to be there. Taking all calls into consideration, about 40% of the time, with the person we met there, we were able to treat in place. We were able to assess their situation, get them the resources they need, and put them back on the path to success without requiring a handoff to another agency or a transport to a facility. But some of the times, 24 and 14% respectively, we did have to provide transport either under traditional methods of calling in an ambulance or another public safety sector and transporting, or we would have to hand off to another agency, perhaps law enforcement, whatever the circumstances required. So that's an understanding of every time the bell rings and we go to a call, this is the probabilities that we found of what the outcome was going to be. For assessment of the actual performance of the team, it's not right for us to consider the times where it was a dry run or there was no person to be found. So this is the exact same data with that red wedge removed. These are the times where there was something for us to do, an action for us to take. And it's not new data, it's just new percentages because we're now looking at the times that the team encountered a member of the public. The system impact was something that was measured real time. So it's, as you know, it's essentially impossible to measure something that didn't happen. And the purpose of this program was to create processes around prevention. So rather than being able to look back into the data and say, how many times did someone not go to the hospital or not go to jail or not require a transport, what I had to do was ask the people who were involved in this, had your team not been present, what do you think would have been the normal outcome of this encounter? Would this person normally have been put in an ambulance and taken to the hospital? Would this person normally have been put in a police car and taken to jail? And the comparison between what they were able to accomplish and what their expertise of our system said what would have happened in the absence of the team is where we come up with these numbers. Sir?
My apologies for butting in with a question, but is there any way to calculate possibly how freeing up these resources might have correlated with a decrease in response time? Or is there any measurable way that we can see that this has led to less time it takes to respond to a 911 call?
Probably not.
Okay.
This size of a program and the number of patients that we encounter, the impact would be small enough it would be challenging to measure from a response time standpoint.
Okay, but it's reasonable to believe that if we had 158 freed up law enforcement agents who could respond to a crisis now, they were likely be able to respond to that crisis
Correct.
faster than if they were busy doing something else. Okay, thank you.
No doubt. Yeah, the response time of an unavailable unit
Right.
is what it is. So when the crews tallied them up, and this was a one-to-one case, they filled out a paper survey for every encounter that they had, talking about some of the outcomes that would have been expected from the norm. And you can see that in totality, we got to about 376 911 resources freed up. This is a little bit of a deep slide, but it talks about some of the dollars involved in this. So we'll work from left to right through this. The titles are on the far left, and then for each individual department, we asked those respective experts to say, when you put out a shift, what does it cost you to do? We need something to compare to. When we go out and we free up resources and we make people available, what would it have cost your department to put that same resource out for the community? And that was to be used as our comparison. We then extrapolated that over not only the actual number of shifts that were done, so we completed 78 and a half days or shifts in the pilot to date. And then we've provided two projections. The first one is a 208-day coverage projection, which would be if we continued this model on a 4 days a week throughout an entire year. That would get us to 208 days. Or, of course, if we were to expand the program to a 7 days a week program, that would be a 365-day coverage. We used those same numbers to figure out what the value added might look like. This term was an area where we struggled. Initially, there was lots of talk about savings, and in fact, this really isn't savings. This program did not save money. In fact, this program cost money. But we believe that the investment in this program had a return of value, not necessarily a cost saving. So if it's easier or makes more sense in your mind to consider this line savings, that's fine. We kicked that around because in totality, it really isn't savings. There's no budget line item that was reduced on this. In fact, the opposite. It was an investment in the community.
Dr. Gallagher, but
Wouldn't you say, though, that it did save in, like, ER admissions?
It did.
Some of those, am I jumping the gun? Because I feel like you say that it didn't
You're-
save any money, but.
You're one slide
Okay,
ahead.
my bad.
You're good. A good question is one you know the answer to, but a great question is one you have a slide for.
Dr. Gallagher, also,
I would pay you the big.
can I, just for the benefit of everybody,
Sure.
the 4 days a week, which is what the pilot was based on a lot of work with all of us to determine
It
hours
was.
and compare it. So if
It
you
was
just-
actually sort of surprising. When we looked into the data, we didn't find the days we were expecting. People were expecting to see Friday nights through the weekend, rough Monday mornings, things like that. And in fact, when we dug into the data, it was the late afternoon and into the evenings of Tuesday through Friday.
Right.
So I would have lost my wager on that.
Yep.
But
Thanks for explaining that too.
all right, so using those value-added numbers, we were then able to project that across what this program might have been able to generate. And then the costs are not necessarily the costs that were incurred to do this pilot, but these were projected costs of what it would take if we were to fund this program moving forward. If we were to add an additional paramedic, an additional social worker, a law enforcement officer, as well as the equipment necessary, what would the cost be to run it? So this is not necessarily what we incurred to do the pilot, right? But what we would project the costs would be to the taxpayers moving forward.
Dr. Gallagher, I have one question.
Sir.
The top lines on this chart show a simple linear extrapolation of what we saw on the 78.5 days. But the cost line is not a simple extrapolation. There's the bigger period of time has a smaller cost per day than the lesser time. Can you please explain why?
Absolutely, very astute. So it accounts from the upfront cost of capital purchase, specifically vehicle, which then converts into a carrying cost as opposed to an initial cost. So as we carry it out into longer timeframes, we don't have to reinvest that upfront cost of equipment.
Okay.
Thank you. And then, of course, the difference is just the difference. So in the amount of time that we have been able to run the pilot so far, we've not actually gotten into the black. This is a program that would need to be run for a longer period of time before our extrapolations would get us to an expectation of a positive number from a finance standpoint. And then, of course, we believe the longer we run it, the more and more you receive.
I actually have another question on this slide. The value added per shift is different for the different lines there. Can you please explain why the law enforcement's 137 and the ComCare's 552? What's being considered to make those numbers so different?
Well, so I can speak to EMS, but each of those numbers were obtained from the respective departments. So I will pivot to my partners to talk about how they calculated their departments. In EMS, it's the total cost of putting out an ambulance for that call volume. So it includes the administrative costs, the vehicle costs, fleet, fuel, personnel, a portion of overtime, all included costs broken down into a fraction of what the EMS portion of that would be. Do you want to speak to the other departments?
The same factors, time, equipment. We all use the same way of projecting this.
Just another simple question here so if, say, a law enforcement officer comes off of your team and they're serving on the ICT-1 team, are you backfilling that officer for his normal shift? Or are we paying overtime for them while they're on ICT-1? Or are we just going without a service of that person, that seat being filled for that shift? How are you managing that aspect of this?
It leaves a vacant spot on their regular patrol shift.
Okay.
In the EMS world, it was your first, we did backfill for that, and there was an overtime cost to do that.
Okay. Are you covering those estimates in these numbers?
Yes.
Cost of overtime is built into this?
Correct.
And at ComCare, we're just leaving that position vacant in our program right now.
Okay, thank you.
And that's the same with fire. That's what we do, is leave a spot open.
I guess I did it differently. We filled the spot. All right. So Commissioner, to your point, there was also some discussion early in this about what's the impact that's happening from the larger healthcare system and specifically the hospitals. Fortunately, Wichita State partnered with us previously and did a cost avoidance study, which had some numbers on it. I apologize, I don't know the intricate details of how they did their study, but we were able to obtain some of their results. So of the 111 hospital visits that our team projected would have occurred, so again, they went through each and every call and they took tick marks as to what they thought would have happened. 111 of the encounters they believe would have resulted in a hospital visit. The WSU study tells us that on average, these hospital visits, 39% of hospital visits will result in an inpatient admission. And then using their numbers, we were able to calculate some cost of the inpatient cost of avoidance as well as the outpatient cost avoidance. And when you get into hospital numbers, the numbers get big fast. So, thank you.
So just touching this slide, and we compare it to the last slide, it appears that when we talk about going into the red, it's the government's, the budget that the municipality and the county is spending is going into the red until the program continues on, which it should go into the black. But the actual taxpayer savings is $1.2 million. Is that a correct read on this?
I don't know that we could connect those because this is healthcare costs which are not necessarily borne by the taxpayers.
Yeah.
People who pay for healthcare also pay taxes though, right?
Correct.
Okay, so maybe a better interpretation or citizen, neighbors might be a better terminology to say our community, people who would normally go to the hospital, if you took all those people up instead of paying a $22,000 of an inpatient stay, through this program, they're avoiding that $22,000, and thus that avoidance is saving those people who would otherwise be spending that money as a community $1.2 million. Is that
All of the payers for healthcare collectively would be saving. Now, some of them would be targets that we don't traditionally think about, like insurance payers. They would also be saving money.
okay? And just one last follow-up. Did your model take into account, was it just the cost of going to a hospital? Now you don't pay that $22,000 for a hospital visit. Did it also take into account maybe the ripple effect of people going bankrupt because they actually can't write a check for $22,000 and have a economic ripple effect as well on how that was the saving of the economic turmoil of medical bills funded into that 1.2?
I don't believe so, but again, this was the WSU study, not our study, so I don't know the detail of that project well enough.
But if it was, it might actually be a higher number of savings for our neighbors. Okay, thank you.
Yep, absolutely. All right, so now for the good stuff. So that's the program and the breakdown from a black and white standpoint, but I don't think any of us got into this for the black and white. We got into it for how we serve the people, which means you need to hear from the people who are actually out there touching the public. So we'll have our storytellers come up sequentially, and then we have a little bit of wrap up from some lessons learned, and then a few closing statements. So, team? No fighting.
Hello, my name is Officer Richard Turner with Wichita Police Department. I've been a part of the integrated care team since the initial portions of the pilot program and have been through quite a bit as far as molding and learning things. As Dr. Gallagher just pointed out, I mean, these were the black and white things, the numbers that we look at, but really each individual case here is a person, right? Each individual person here has a family. You mentioned ripple effects, and every call that we've been on does really have these ripple effects. And the real question that can't be answered, as Dr. Gallagher also pointed to, is what would have happened had we not been there? We simply don't know. I can talk about a lot of different situations, a lot of different calls that we've been on, and some of them have been pretty profound. And some of them really did have an effect on the services in the area during that time. Near the beginning of our pilot program, we had a woman who was homeless. She's about 60 years old, and she lives at an intersection close to the Walmart, way out on West Kellogg and Dugan. right? She's been there for years. It's been her spot. And she normally sits at the bus station or she sits on a drainage ditch there. And everybody's seen her. Well, at the time of our call, within 48 hours prior to us arriving as a team, we had received over no less than 10 calls about her wanting us to check her welfare. She'd been sitting outside in the heat. She had been, every bit of her skin that was exposed was sunburned to some degree, and people were concerned. People became so concerned because she had gotten to a point of being so sick and ill that a city bus actually had to be pulled off of service because she had been unable to control her bowels on that bus. But she's an intelligent woman, right? So when police would come out and or EMS would come out or anybody would come out and say, hey, we need to help you. We need to get you to a hospital. She would simply say, no, I'm fine. I'm okay. I'm okay. And legally, there's steps, right? We can't force care on people unless we can demonstrate or they demonstrate an inability to show decisional capacity, right? If they don't fully understand their decision, then we can intervene. But the fact remains that when EMS went out by themselves, when police went out by themselves, there was not enough collaboration to really determine that, and especially without having a qualified mental health professional to be able to really determine her decisional capacity. So when we went out, like I said, there was no less than 10 calls in the previous 48 hours. And when we met with her, we had already been discussing it collaboratively, expecting to have another call. So we kind of had a little bit of a game plan. When we went out there and we met with her, it was astonishing to me to see not just her, but she had friends and she had family who came around as we were on the call with her for about an hour and a half. And when I spoke with her initially, she says, no, I'm fine, I'm good. I don't need help. And I should describe it to you. Not only is she sunburned, but the sunburns had became so bad that her legs had such a severe amount of sunburn that they had cracked, they had burst, they had become infected. And the paramedic on the team had believed that she had been approaching sepsis or maybe in sepsis at the time. It was pretty clear that if we did not do something, if she did not get to the hospital in the next few days, more than likely she would pass. Because of our collaborative effort, because of having a qualified mental health professional, because of having the Office of the Medical Director and law enforcement agencies there as well, we were able to really speak with her. And we ended up finding out that the reason why she said she was fine is because she didn't believe she was sick at all. She didn't believe she was sick because of her mental health symptoms. In her mind, she believed that these aren't real injuries. No, this represents one thing and this represents another thing, the turmoils from her life, but they're not real injuries. So we were then able to establish her decisional capacity. We were then able to take her to the hospital. We were then able to tell her sister who came on scene that, yes, we are getting her some help. And then she spent a couple of weeks in the hospital in the burn unit. I actually ran into her randomly on another call as she was leaving the burn unit and going to the mental health side of the house, and she looked completely different. Her hair was no longer matted. The nursing staff there was fantastic and gave her a makeover. She was lit up and excited for life, which she was definitely not the first time we met her. Each one of these numbers is a story. And each one of these stories has family members, has friends, has other impacts within the community that will reach way further than simply saying, oh, it's worth $22,000. It's hard to put a number on the people we care about. Thank you.
My name is Brian Shasted. I'm a paramedic with Sedgwick County EMS. I've been privileged to be part of this team since the beginning of the pilot program, beginning at the end of July last year. And I want to echo a lot of what Officer Turner said and Dr. Gallagher and some of the other leaders up here have said, that it's easy to look at numbers, but to put a face and a family and real life stories with those numbers, I hope really helps you realize just what this team really is about, and I'm proud to be able to be a part of that team. One of the stories that really came to mind from my perspective as a paramedic is a lady that a welfare check had been called in for her just as somebody walking around downtown with no shoes on. It was still hot in the year. It was a sultry kind of day. It was getting later in the evening, so we came to check on her. And as we checked on her, we found that she didn't seem completely out of it. She was able to carry a conversation, but the difference between working on an ambulance and working on this team is that we do have the ability to stay longer and be able to dig deeper with somebody. So this lady, we were able to determine by speaking with her and starting on her medical history, because there still is that stigma, even in 2020, United States, there still is that stigma of mental health where people aren't comfortable talking about their mental health issues, even to a mental health team. So I opened it up with asking her about her medical care, what medicine she takes, how her health overall is doing, can I take your vital signs? And in the process of doing that, we were able to find out that not only was this lady neglecting her mental health, she was also neglecting her physical health. And we were able to determine that she had a high heart rate, her blood sugar was out of control, her blood pressure was out of control, that she was a very sick lady. And this was one of those that, yes, she did end up going to the hospital by ambulance, but that was determined because we were able to, as a team, approach her and determine that she needed to be in the hospital. Now, she had been to the hospital prior times before, but every time she'd walk out. And EMS had encountered her times before, but due to the time constraints of being on a busy service and the patient at that time being able to say, nope, I'm good, I don't need to go to the hospital, just do a quick set of vitals, sign here with your liability and be on their way to the next call. With this, we were able to really determine that she did not have the decisional capacity to make those decisions. The more we talked to her, the more we realized her speech was disjointed. She wasn't able to keep her thoughts together. She wasn't able to really demonstrate that she was fully in touch with reality and that she had any kind of insight into the state of her health, similar to what Officer Turner said with his story. So we were able to get this lady not only to the hospital, but get her in a way that she wasn't going to be able to elope from the hospital like she had done in the past. This time we were able to, because of the presence of the paramedic person on the team, we were able to bypass triage, take her straight back to a room that was further away from the doors where they were better able to watch her. And then she ended up being admitted for several days, getting her healthcare needs under control before she was admitted to get her mental health needs under control as well. So again, she also had a family. She had people that cared about her. She's a member of the community like anybody else and just as deserving of the help that we provide. So I'm glad that we on this team were able to provide that for her.
I just want to stick one other thing in before we hear the third story. What he didn't mention is the medical team has in fact performed so well that we have been able to start conversations with the hospitals about bypassing the emergency department in its entirety and moving people directly to mental health and behavioral health admission process. So to be seen as such high quality that they don't even require the physician assessment in the emergency department is noteworthy. So congratulations.
Just for clarification, that's a cost savings of $22,000 per person who can avoid going through the emergency process, according to the previous slide.
I would certainly have a cost savings. I'm not 100% sure exactly what it would be, but skipping the ER is a good way to save money.
Thank you.
Sorry.
Hi, everyone. My name is Sarah Slifer. I'm one of the qualified mental health professionals from ComCare that was part of the initial 90-day program. I want to reiterate the importance of having a team collaborating together to come up with better plans than if we were working separately. For example, many times if someone is in a mental health crisis, kind of the protocol for law enforcement or fire EMS, depending on the situation, is to take them to the hospital. And in some cases, absolutely, that's what they need. However, many times, that's just another trauma added to their life, especially if it's involuntary. That's another person overwhelming the emergency department system and the mental health system in our community. So with that in mind, with bringing the mental health piece to the person, we're often able to come up with safety plans or provide more tools and resources to actually help the person and resolve the situation they're going through. And that we can get pretty creative in our safety plans. We can follow up, we can have someone from crisis calling and checking on them, all sorts of different things. And on the flip side of that, many times when law enforcement or a paramedic goes out to see someone, they're very aware that that person needs help, but they don't have enough pull to justify forcing that person into getting help. And of course, the goal is never to hospitalize anyone involuntarily. It's definitely the least fun part of the job. However, it's an important part, and in some cases, it has to happen. So being able to have the team together, working together, where we can facilitate people getting the help they need and thus avoiding them getting sicker, potentially getting arrested, repeated 911 calls, all those other things. So for the specific story I'd like to share, there's one evening, I think we got this referral from ComCare. The family had called not knowing what to do. This was a fairly young woman who had broken her back about 10 days prior from a suicide attempt. She was in her family's home. Due to her injuries, they were not able to give her the care that she needed. They didn't know what to do with her, honestly. And as we got to talking, I think the three of us all did very well at engaging her, building rapport. It determined that it came out that she was still suicidal and she was still very much struggling mentally. So this was, when I worked, probably the biggest teamwork that I observed. I was able to kind of talk with her about what her options are on the mental health side of things. Officer Turner worked very hard to call different shelters, domestic violence shelters, things like that, to see if any of those had resources to help her. And the medic was able to safely get this person into a vehicle when the officer and I probably didn't have the skills necessary to help her. She very much needed help, even standing up, moving around. So what ended up happening with her is she did go to the hospital willingly after the medic helped her get cleaned up. Luckily, we had a female medic that day. This lady had not been able to shower in a week. So just providing her with that opportunity to get cleaned up before she basically gave her rights way to the hospital, that provided her with her dignity again. That showed her that we actually cared about her. All three of us genuinely cared about her and wanted to do something for her that was going to be successful. And unfortunately, I haven't been able to follow up with her, so I don't know how she's doing, but I hope that, and I can speak for the team, I hope that she's doing well, and I think that us being there definitely impacted the result of that. Thank you.
Thank you, Sarah.
Some of the lessons learned in this pilot was the demands of the work. Now, we've talked many times about how more and more of the mental health issues fall on the backs of the criminal justice system, whereas it's not a criminal justice system issue, it's really a health issue. But because of lack of resources, we continue to have criminal justice as well as other parts of public safety pulled into this crisis that we're in. We know that it's demanding on our staff. We talked about, you hear these sensitive cases, really they're heartbreaking cases, and when you're dealing with that day after day, there is a cumulative effect. We do see burnout with staff when it comes to dealing with these issues. And we get You get people entering these fields that really do care about people. And day after day of dealing with these types of crises can have an impact. The documentation is lacking in many different aspects. One area that we've talked about further is a collaborative database that collects all of our information to help us be more effective in dealing with people that are suffering from mental illness. There is not one system that everybody can use. I would love to have ComCare have access to our calls related to suicide threats or mental health related calls and collaborate with them on doing follow-up, because so many of our calls are repeat calls on the same people over and over again. And we know the formula is to get them stabilized, but our systems aren't built to collaborate in that way where they can see how many times this individual has called us and how many times we've dealt with them. That is an important part of successfully addressing the issues that we are talking about today. Obviously, staffing impacts all of us. You heard us discuss how we've pulled people from other areas, in many cases left positions vacant, as well as several of the team members need to keep up on their training, that they can't do this full-time because they lose their skills that are important, say for paramedics, that they need to be using on a regular basis to stay at the top of their game. We lose team members to injury, illness, promotions, and that can have an impact. So there is a desire to expand the team so that others learn and gain the expertise associated with this collaboration effort. There is a proposal to create 3 teams and a 1-unit rotation that will address the burnout issue, as well as bring more people into the unit in case we do lose someone, and that is as portrayed on this slide here. I don't know, Doc, if you want to add anything to that or not.
You got it. You got it. Okay. The idea is to give them some time on this, to rotate through it, maintain that expertise, but also be able to rotate off and go back to their traditional functions so that they don't lose their skills of being an officer or of being a paramedic or of being a firefighter, but all the while keeping them engaged so that when it is their turn to serve on this team, they have the expertise to do the intricate work that we just heard about.
The areas that we can improve on, we've got to continue to focus on the follow-up with the suicide threats, the nuisance behavior, those calls that are driving our neighborhood issues that all too often you know about. This problem area is oftentimes by an individual. And to have the time, so our mental health calls, when our officers go on mental health calls, we know they take about twice as long as your average call. We talk about use of force in policing and the importance of slowing things down and communication. Well, when it's busy and we're getting complaints from people that I waited extended period for a burglary response, that's in the back of these officers' minds. And they feel rushed when that radio is blaring and there's nobody to respond to calls. And to give these the staff the time to take their time on these calls and work through them and be thorough and focus on sustaining their efforts so that we're not responding out there the next day and really helping these individuals, they need that time. And also to follow up on suicide threats or incidents that are happening at 3, 4 in the morning when they're not around, where they can go and use their expertise and their collaboration to lower these calls and get individuals the help they need. The direct admit was mentioned. If we can cut through, cut off the ERs, which can be long wait times, in addition to the costs, are problematic. We need to continue to grow the collaboration with others in the community, involve the homeless outreach team. We know that chemical dependency is often a lot of the mental health issues we deal with are, we're seeing an increase in drug-related psychosis, which are driving a lot of the issues with the increase in jail admits, the increase in criminal charges as well, where if we can get some type of chemical dependency treatment available. Someone came to us today and said, I've been committing burglaries, I'm on meth, I want treatment, can you help me? it would probably take about 6 months before we could walk them into treatment. So what happens is they go back to their ways. There really needs to be some other options for people, which you'll probably hear about through our other collaborative team that we're working on.
I just want to add a few more lessons learned after hearing everybody speak. You know, mental health conditions are brain disorders. Brain disorders are physical disorders. And we know that you improve a person's physical health, you improve their mental health, and vice versa. If you improve their mental health, you improve their physical health. This pilot program is the absolute example of trying to address both collaboratively. And I will say this team is really phenomenal. We have had just outstanding collaboration among all the leadership, but the team has gelled so quickly. I mean, they were supporting each other within hours of being on that van together. You know, you just have to work collectively. And I'm going to throw out a technical term because what we also found, like the hours, we didn't expect the hours and the days to be Tuesday through Friday. We expected them to be overnight Friday into the weekend. We also learned that the population we're touching through this pilot are not the people that are walking through traditional doors. These are folks that don't really recognize many times that they have a mental health condition, as Officer Turner spoke to. The technical term for that is anosognosia. And it is a true and real symptom for a subpopulation of people that have mental health conditions. They don't recognize it. They don't know that they're struggling. They don't know that others know they're struggling. And it's very different work to engage that population than your traditional person you're going to encounter in any of these other intersects. So we also learned that course correction is going to be pivotal to making this program successful over time. We all knew going into this that we were testing some theories, testing some thoughts, and over time we've discovered that there's probably a need for some change. Positive change, because we've learned about what each other's strengths are and where the passions lie and where the team works best together. So when this group comes to the council or to the commission for funding, it's going to look a little different than when we originally talked about in all likelihood. So what we have found is that we think that Wichita would be supplying the technology and the equipment and the police representation on the team. And we see the county providing support from the mental health services and from EMS for the paramedics. So little different than we originally started. If you remember, we started with, I think, 7 different collaborative partners, and we shared some roles, and we think we need to more clearly define those. And I think everybody up here on the leadership team feels this is the best direction to go at this point. So with that, we've learned a lot. We value one another. We value the interactions in the community, and I can't underscore the fact that it's not just about the individual we're serving at that time. The nice thing about being out there and intersecting with families is you can bring the family along with the issue as well. Oftentimes, if you're picking up and transporting to the hospital or you're transporting to crisis, privacy laws will prohibit some communication with family. This way, when they're there and they're involved in the interaction, we can get them involved in the outcome. So very powerful program. You heard the stories. There's nothing more impact than what they've already shared. So with that, we stand for any questions you might have.
I have a question.
Madam Vice Mayor.
Thank you.
Playcom.
I was, Chief Ramsey, you said in kind of passing that if someone came to us and needed help, it could take 6 months for them to get that help?
Yeah, not only is there a shortage of mental health inpatient treatment, and I'm talking inpatient, it is significant delays and times in getting people the help they need.
So they could get examined and they could get a diagnosis, but then getting them to their treatment place would...
Correct. And it's true with not only chemical dependency, but also mental health. So often we drop people off at a hospital for mental health treatment. They're suicidal, and oftentimes they're released on a voluntary plan, and we're back there again the very next day. The system, we need to fine-tune the system so that there is follow-up with these folks sooner than when they are, than what is happening right now.
Okay, thank you.
Can I add something to that?
Yeah.
And I think, that follow-up piece, this is where everything starts, like, kind of colliding, and, you're starting to fill in those gaps, but for the current upcoming budget year for the county, the commission approved us to add 2 mobile teams. We see them as providing that follow-up going forward when we get those positions filled for the folks that are being seen initially through this program. So we think we have some plans in place, and we're just going to keep evolving.
Chair recognizes the Honorable Commissioner Dennis.
Thank you, Mr. Mayor, Mr. Chairman. We appreciate the opportunity to speak. I've been a supporter of ICT-1 from the beginning. I've had an opportunity to ride with them in an actual call to see how that they operate. I think the teamwork between the city of Wichita with the police department, with the teamwork with the county, with our 911, EMS, ComCare is fantastic. I think that the citizens want teamwork between our 2 governments. This is exactly what our citizens are demanding. I am very proud of what Dr. Gallagher came up with. I fully support this. I certainly hope the city of Wichita supports it, and our commission supports continuation of this. It's going to continue to evolve in the future as we learn more and more lessons. But I really, at one point, we kind of stopped this because the pilot was over and we didn't know where we were going. So it stopped for a period of time, and we actually had to take action to start it back up. I don't want to see it stop again. What I want to see it evolve, and I want to see that we have the funding available from both the city and the county to be able to help this evolve.
Well said. Others who would like the floor? Councilmember Clendenin.
Thank you so much, you guys, for everything you're doing for our community. I don't think that we really can quantify. I mean, you guys have made that point very clear. And I'm going to ask you a little bit of an unfair question because I know we're still in the middle of piloting this. There's lots of lessons learned. But based on the data and the things that you see right now, if or as we move forward with the integrated care team, how many teams can you foresee us needing to be effective citywide and maybe even countywide?
If I can start with that. Keep in mind the history here. So the mental health issues have become more and more local. Decades ago, it was more of a state issue. Many of the people we were dealing with 40, 50 years ago would have been hospitalized, institutionalized. Now, it's our primary duties to deal with this. If the state can come forward with some funding, that would be very beneficial for us. Right now, we have a hard time getting people committed that need to be committed. Sometimes it's a day or 2. Joan can talk a little more about that. But there needs to be a state component to this as well, right? It can't be all on us. But the mental health issues are not going away. Whether it is organic or drug-induced, we're going to have to deal with them. I can tell you the success of this team is the model for the future in cities throughout the country. That co-responder model where people are not operating in silos and are working together has to be done for the success of some of our most vulnerable people.
So you're such a good politician. So I hate to put anybody on the spot, but I understand the funding component of this, and one of the other projects I'm working on, I had to tell one of the teams of people I had together, so in a perfect world, if you had your way with things, knowing that the world is not perfect right now, if you had an ultimate goal, how many teams do you think, at this point with what you know, I know that can change, and I'm not going to hold you to this, but spitball me a number. How many teams do you think it would take to be effective?
Sure. So
I got to imagine your team can't handle every single call.
No, not even close. So, I mean, there's a couple things here. So effective to what degree? Because right now, this team is spectacularly effective.
Yeah.
Have they reached the capacity of what the system needs? Absolutely not. Right. And so I'm going to give you a number. I'm not going to dance around the whole thing. I think my suspicion, I'm going to put my chips on 4. Okay. I think that would probably get us into the ballpark. Now, that's a guess. right? Just as if I were starting you on a dose of blood pressure medicine, I'm going to start with what I think is right, and then I'm going to adjust it based on the findings. So what we really need to do is we need to slowly start titrating the dose up to find where the effective number is, measuring it all the way. But to not avoid your question, 4.
I don't think there was an intentional avoidance, but, well, you know, we know that our EMS, our police department, our fire department are all effective, right? Maybe that was the wrong term on my part, but everybody always needs more funding, and we get that. But I just think that the funding put in this direction really saves us in a lot of areas. Not only that, but the care that people are getting and the quality. This just really revolves around quality of life for everybody in our community. That's just a buzzword we'd love to use is quality of life, and so that really helps. At least having a number, kind of a goal for us to shoot for, and helps us go to the state and say, you know, this is what we're doing, and we need the money to be able to help do this. So we appreciate it. Thanks.
But if all you had was 6, we'd make it work.
Gotcha.
And I just have a comment, then a follow-up, and then I'll recognize Commissioner O'Donnell for the floor. It seems that, and I think your analogy is appropriate, where in public policy we want to be agile, where it seems like if we give you, and correct me if I'm wrong, give you enough teams to kind of start this off, it's reasonable to believe that we might be able to pull back with less teams as people now are getting the care that they need. They're having less episodes, less issues, and then hopefully, you know, as we adjust, that the amount of teams, the amount of expansion of this program would wind down as people are receiving the care that they need. Is that a fair assessment?
Yeah, we want the right response for the mission.
Okay, very good. Chair recognizes Commissioner O'Donnell.
I don't get the honorable like this guy did.
The honorable.
No.
The honorable.
Kidding. Thank you,
Commissioner O'Donnell.
Thank you, Mr. Mayor. And thank you to all of our presenters today. I know that ever since I became a commissioner, people wanted us to do something with mental health, and I think we've really assembled a team of visionary people. Joan and her team at ComCare do an outstanding job. Chief Snow having the fire department come and embrace this and even providing the vehicle was above and beyond anything that you needed to do. So I know I'm very appreciative of that. Dr. Gallagher continues to prove himself to be a visionary. Not just in this field, but also in EMS, what he's doing there, and our community is very lucky to have him. And Chief Ramsey, just the credibility that the Wichita Police Department has instilled in this program and what you've been able to do for our entire community over your short tenure here, I think this is really just a phenomenal attribution to your leadership as well. But mostly to Bob Layton and the City Council for embracing this. Mental health has historically, like Chief Ramsey said, been a state issue, and then it became a county issue. So you did not have to do this. You went above and beyond. You took money out of your budget, out of your police and fire and the most essential programs you're offering. You came and assisted the county. And that's something that needs to be a model on not just mental health, but everything that we do on a daily basis. We need to be embracing each other, but this truly affects people's lives at the end of the day. That does make a difference in our community. So that's not lost on us across the street. The fact that you put your money where your mouth is on this when you didn't have to speaks volumes about your commitment to mental health and substance abuse and a lot of the problems that we're facing in this community. So as a commissioner and as someone that sits on the Board of Health, we wouldn't have ICT-1 if it wasn't for you guys actually embracing this and taking your limited tax dollars and putting it in a program that the county really needed help with. So kudos to the City Council for making this happen. So appreciate it.
Much appreciated. Comments. The Honorable Jim Howe of the County Commission.
Thank you.
Yeah,
Honorable.
before I do, I'll tell you, every time I say that, someone whispers to me, you got to say it to everyone now or someone's going to you're going to get in trouble, and that's just a reminder I do, so please.
Thank you, the Honorable Mayor Whipple. Appreciate the recognition. I want to say thank you for the presentation this morning. This has been a very interesting topic. I think that the city and the county have certainly identified mental health as a priority, and I think that that's commendable, and I think we ought to come together and find the best solution, and I appreciate the conversation today. I think this is a step in the right direction. I do have some questions. I do think that we ought to be absolutely data-driven. I don't want to be convinced of a side before we look at data. I think that everything ought to be on the table. We ought to be questioning, is this the best we can do? And so I do want to understand this data. I think the data does matter to me. So with that, I have a couple questions on the data. First of all, if you go back to the columns, I think it's on slide 5, it shows that you did transport 45 people for inpatient, outpatient services, but on the other slide, it talks about 111 inpatient, outpatient cases were avoided. So I guess I'm wondering, does the 111 take into account that we did have 45 transports for inpatient and outpatient services? And if we did, you have to add that up, and I believe the number really is, I have the number here already somewhere. I don't know if my question makes sense or not. But do you see the two tall blue lines there? By my guess at those numbers, I think that's about 45 transports for inpatient, outpatient. I should say. We don't know if it's inpatient or outpatient. We just know it's voluntary and involuntary transports for hospitalization of some sort.
Correct.
That's
Well,
about 45.
they were transported. It doesn't necessarily guarantee that they were admitted, but it does say that.
Right, and I stated my question incorrectly. So again, when I see those, these are either inpatient or outpatient hospitalizations of some sort, some type of services.
No, they're just transports to the hospital
Okay.
for determination whether they could be managed inpatient or outpatient.
Okay, but either way, they probably received one of the services in or out.
Got to be one or the other.
Got to be one or the other, okay. But now, there's a slide that talks about the Wichita State University cost avoidance study. You guys say there's 111 visits were avoided. Is that relevant to the 198 that you interfaced with
So
over a period of time, or what is that?
111 was a measurement by the team, boots on the ground, projecting what they believe the typical system would have resulted in that patient's outcome. So yes, those are within all of the patient encounters.
Okay.
Now, there's no guarantee they're right. These guys are pretty good at what they do, and I'm confident that when they said, under normal circumstances, we would have taken this person to the hospital, I believe them.
Okay, very good. I am curious about, I think the 3 stories I heard, I was trying to listen carefully. Were any of those interfaces dispatched by 911, or were those interfaces created through other way to connect to those people in the community? How did they get connected? Did 911 dispatch the team, or how was it that?
So because we didn't have the intricacies of exactly what call criteria would be best for the team, we did not place the burden on the 911 system of assigning these calls. Now, some of them came from within the 911 system. These guys were real-time monitoring the system, would see a call come out, identify using their expertise, not the dispatchers, that this was an appropriate call for the team, and they would take it. So rather than being assigned it, they would take it from within the 911 system.
Okay, now in the future, if this is stood up as a persistent mobile mental health strategy, do we anticipate that 911 would actually, in that case, dispatch this team, or are we going to continue our current way of doing that?
My hope is that it would be collaborative, although I do believe that as we refine this and we understand it better, we would be able to establish criteria that the dispatchers could identify as this is a high probability call for an ICT-1 team.
Okay.
But I don't think I would ever want to take away the team's ability to say, this is in our bandwagon, give it to us.
Can you please remind us the hours that I guess they were 10-hour shifts, I understand, but what time did they initiate their team each time they came together? What were the hours that they operated?
2 p.m. to midnight.
2 p.m. to midnight.
Commissioner, if I could say something real quick too, the popularity among the police officers on this, and when you talk about how they're dispatched, frequently I would hear officers asking if ICT-1 was working and if they were available because of the complexity of these cases and the time involved. So if they weren't dispatched, I know oftentimes other officers were asking for them to respond.
Yeah, that was huge in EMS. That you'd get a call for is ICT-1 available, and the dispatcher would say they're on another call, and you could just hear this collective, dang it.
Okay. I am curious about a comment. I think the chief mentioned a minute ago. You said a lot of times these issues are escalated with substance abuse issues. I think we all kind of know that. I am curious on that chart there, why, it looks, again, trying to interpret the bars there. Looks like SAC only had probably one case. And SAC is our sobering unit. Am I correct about that, Director Tammany? Why is it we only had one case that ended up in our own sobering unit, if I'm reading that correctly?
Well, it's difficult to say. Oftentimes it can be, sometimes their behavior isn't appropriate for SAC, where they are causing a disturbance, where they're problematic, where they probably wouldn't be allowed there because of their conditions. Go ahead.
Thank you, Chief. And that is a very good point. I mean, a lot of times it's not the appropriate answer right there. Yes, the fact of the mental health issue as well as their substance abuse issue can be comorbid a lot of times and can pair off of each other. However, what we try to do is find the most effective answer for them that day, the most effective path to a better life. And a lot of times SAC just isn't that. SAC is a great facility, it's a great for the community, but just wasn't great in those individual circumstances. And it's hard to say why, because each situation is so different, sir.
I guess I'm just surprised with the large number of cases here that, again, apparently only one of them actually got to the sobering.
To give you an example, sir, if we're going to a mental health crisis call, it could be because a family member called 911, it could be because it was a mobile crisis unit on the mobile board for ComCare, it could be EMS brought us in, all these different reasons. But a lot of times when it gets to a point of a mental health crisis, that crisis supersedes their addiction, right? So that crisis there needs to be addressed before we can really address the addiction portion of things. So it's not necessarily appropriate for somebody who's actively experiencing homicidal or suicidal ideation to go to a sobering unit. They need to go to a hospital.
And, Commissioner and team, I think we have other comments and questions, and we need to, and some of that detail we can get one-on-one if we need to, so.
That's fine, I'll stop talking. I do have other questions, but I'll get to them if I have time. Thank you.
Very important discussion. Chair recognizes the Honorable Council Member Bluebach.
Thank you very much, Mayor. I appreciate everything you guys are doing. I appreciate coming up with a proactive solution that is far outstanding some of the things we've seen in our community. One thing I'm interested in is, are we seeing this happen in a certain area of town? Is it more something that's happening inside of 235 in the suburbs? And do we have like all the data you guys have provided here, is there any way we could get like a plot map to show where the occurrences are happening? I'm just trying to, I don't know if you can answer any of those questions and kind of tell me where you're seeing this.
We've got a heat map we can send out to all
Okay.
of you, where the team was focused. We could also show you where the most mental health calls are, separate from ICT response, whatever you'd like.
Okay. Do we have just kind of a 50,000-foot view of where we're seeing it right now? Can anyone answer that, or?
50,000 feet from there. Can you see?
So mainly downtown.
Yeah.
Okay.
So in the previous 90 days, I'd be glad to give this to you for a moment.
We have that. It's been shared before.
It was provided to both groups previously. We can get you an additional copy.
We don't have it today, though, do we?
Correct. It was at the previous meeting. So in broad strokes, it represents where the traditional call volume is, that this is a subset of the rest of the call volume that we run, but we'll get you the detail.
Okay.
And it would be good, sorry to jump in, it would be good to see even on some of the calls where they were requested but couldn't come out as well, not just where they were deployed, but, the calls,
That were missed.
if it's possible.
You don't
You don't track that? Okay.
Yeah, we track mental health related calls, but many come in as disturbances or check welfares. They don't come in as like a psych call. So oftentimes to get into to really do the deep dive, we have to look individually at calls, which is very time intensive. But we know that about increasingly, we're looking at about 25 to 30% of our police calls have a mental health component.
Mr. Mayor, thank you. And just to recap, thank you that things like, I know Councilmember Brian Fry and I were involved in some of the early discussions, watching all of the departments come together. 911's not here, but they've been a big part of it, as you know. The sheriff is not up there, but he has had if we were all looking at financial impact, the fact that we avoided X number of bookings and jail time is another financial component that's beneficial, and it's really for the community. So I've enjoyed hearing the stories and seeing what you recommend. I think you're right. We started with 7 agencies all split in time. You've isolated it down to 4 or 5 with specific roles. That's incredibly responsible maturity of this program and your flexibility. So want to thank, in the recommendation of 3 or maybe 4 groups rotating to keep your people fresh. Fantastic idea. One that us as elected bodies wouldn't come up with because you're living it and breathing it. So my sincere thank you. And again, Dr. Gallagher, your leadership and Chief Tammy Snow, you've been fantastic coordinator from the start on this. And on behalf of myself, and I think Brian Fry was great to be a part of. Well, we were just a witness. We didn't get to really contribute anything because we didn't know much. But it's been rewarding, and thank you for the impact you're making on our community.
And I echo the comments of Chairman Meissner. Want to thank you, and I believe unless there is any burning or pressing questions, we should be mindful of time and the fact that we have a mental health and substance use coalition update following this. So is there any objection to moving on to the next item? See none. Again, we thank you, and thank you for all you do, and we're looking forward to the continued updates on the success of this program. Next item of city-county business is an update on the Mental Health and Substance Abuse Coalition. Chair recognizes, I believe it's Sheriff Easter and Joan Tammy.
Thank you.
Welcome, sir.
Thank you. I'm getting over a cold, so you have to put up with my voice for a little bit, but I appreciate the opportunity to come up and speak to the commission and the council members today. What we're going to discuss is what's been going on for the last year in reference to the Mental Health and Substance Abuse Coalition. As many of you know, this started almost 3 years ago with different groups of folks coming together that are having to deal with mental health and substance abuse. From the private sector in reference to Via Christi, to ComCare, to law enforcement, the DA's office, SAC, and some other entities. A lot of the stuff that was taking place was due to the fact that at the state level, there's been a breakdown. I'm not here to pick on the state, but there's been an absolute breakdown in the mental health system. And it's been over a period of several years, and it's finally caught up to us. So after we got through pointing fingers at each other, because we were all pretty upset with each other on how things were going, and we worked through those issues, we were able to come to a conclusion that we are going to have to address this issue of mental health and substance abuse here locally ourselves. And so at that point, we started putting together committees in reference to mental health and a separate committee in reference to substance abuse, because both those issues are so big, it was hard to handle in the beginning with the same amount of people and the different entities that you have to get involved. And so from that point, it moved on to what we now know as the Mental Health Substance Abuse Coalition. And what has occurred there is that we combined both of those entities, from the substance abuse to the mental health issues, because what we found was it's a lot of the same partners, a lot of the same groups that are working on these issues, including homelessness. And so now homelessness was added to the group as well, because a lot of the folks that are homeless suffer from mental health, or they suffer from substance abuse, or a combination of both. And so what we'll start stepping you through here today is we have completed the strategic agenda process. And that was about a year-long process, because we needed to meet with several of our stakeholders out in the community that are dealing with homeless issues, that are dealing with substance abuse issues, and are dealing with mental health issues. And so we tried to connect with a lot of different entities, including WSU, WSU Tech, different private entities, plus the folks that are providing these services. And we've always, every time we've put out a meeting notice, we've added more folks. And the reason for that is that we didn't know who all was out there doing what, to be honest with you. And so from those meetings, we gleaned a lot of information on how to proceed with putting together some type of plan. During the course of this time, there was a lot of talk about the San Antonio project. That is an entity that we went to visit to see how they're doing it down in San Antonio. It doesn't mean that we're taking that particular process and implementing it here, but that is what we were kind of looking at, because it's kind of a model for the country of how to combine all these services into kind of a one-stop shop. And so we've learned some ideas from down there. What we did learn, it took them 18 years to get where they're at now. There's a lot of things that are in place in this community that they didn't have when they started. So we're ahead of the process from when they started 18 years ago, which is a good thing. And so from that and those initial meetings, a board was put together that consists of Terry Moses with USD 259, Todd Johnson with Wichita Metro, Eric Wichita Metro Crime Commission, Joan Tammany with ComCare, Robin Chadwick with Ascension, Harold Casey with Substance Abuse, Chief Gordon Ramsey, myself, Deanne Smith with Open Door, Gary Schmidt with Entrust, Mark Bennett with District Attorney's Office, Rick Kirshen with the Law Company, Steve Dixon with Hoydale. Commissioner Lacey Cruz was recently added from the commission, and City Council member Cindy Claycomb was added from the City Council. So what started out as a smaller group has blossomed into having private entities involved in this, because we want that private-public partnership going forward. Because when you're talking about these issues, and the previous issue that you guys talked about is funding. When you talk about what all probably needs to take place in this community, there is no way government's going to be able to afford that every year. No way possible. And so we have got to develop those public-private partnerships. And so that's why you see the diverse amount of people that are on the particular board. With that, we enlisted the help of Author Bradley. WSU conducted a lot of outreach for the board to look at who all needs to be involved in this process and to get stakeholders' input into the strategic plan. Author and Bradley helped develop the plan, but there was a course of several meetings that took place to have that input put in there. The other thing that has happened is there was several studies done by ComCare and Ascension Via Christi to really look at high utilizer numbers and to look at other type of mental health and substance abuse issues that are going on in this community, so we could have that pertinent information to start building the plan. So I know it took us almost a year, but there was a lot of effort put into this. Again, the coalition has a chance to put structure, benchmarks, and resources towards serving the community in effective and efficient ways while using best practices learned through research in Wichita and studies from communities across the country. Coordinators Jennifer Wilson and Wendy Hummel were both positions that were hired by the county to help put this process together and help to continue it forward, because everybody that you saw on that list of board members, we are all have our full-time jobs. And that's what was taking so long over the 3 years to make any progress whatsoever, is because we could only put a limited amount of time to it. So we had to hire some positions to keep moving this forward. The outcomes that we are going to see from the strategic plan defines a vision and a mission for the next 5 years, values that will guide the work of the coalition, establish common goals and priorities, is based within the context of the overall community for substance abuse, mental health, and homeless needs and services. One of the last things that I'll speak about, then I'll turn it over to Joan to talk about specifics in reference to the strategic plan is that the ICT-1 project, was something that a lot of the folks that you're seeing on this list was a part of, because we know that there needs to be change. The ICT-1 is a program that blossomed out of some of the discussions that we've had for the last 3 years on this, and I think I hope it proved the successes you're seeing out of that. And so I think that with those type of successes, with what we're trying to do with the coalition, those are all successes that we can expand upon. And so I hope with any type of questions you might have and those type of things, Joan and I will stand for any questions that you have, but I'll turn it over to Joan now to go over the intricacies of the plan. Thank you.
Thank you. Joan, welcome and good morning.
Thank you. Just an FYI, I know it seems like we've been talking about this for a long time, but this is a really complex, complicated issue, and we often hear, get it done, and I just want to say, it's going to take time to get it done. It took a long time for us to get here as a community and as a society in general. It's going to take time to find what works and to get those partnerships in place. So recognize that while it doesn't look like there's any formality, a lot has occurred. I mean, building relationships is time consuming and it requires continuous effort. And, as we moved into the strategic planning partner, we had to learn each other in different ways. And we learned about WSU and the strengths they brought to our team, and Bradley and Bothner as well. So I know everybody wants it done. Just be patient with us. We're going to get there. It's just going to take a little effort. So let's see.
As electeds, we hear get it done a lot too, so
I know.
we understand.
It's true. And I will say something the sheriff said. I was in Topeka for the last 3 days advocating for funding, and that's always a challenge. But one of the things I heard from all the other providers that were up there and other agencies familiar with behavioral health and substance use issues, and then a lot of the legislators and senators that I visited with while up there, everybody is looking to Sedgwick County because they know the funding isn't adequate that they can provide. And so they're looking to us to see if we can find some efficiencies and some solutions that can be then modeled in other communities. So the eye is on us, and we have a grand opportunity with this. So I just wanted to start with this particular slide because I think when we talk about behavioral health or mental health specifically and substance abuse specifically, everybody has a different interpretation of what that is and how broad that group is and how do they intersect. And this coalition is focused on that absolute intersect. So right there in the center, we're talking about the people that overlap homelessness, those with substance use disorders, and those that may or may not be homeless. So we're talking about a smaller population, and these are those high utilizers. These are the people that are using resources in all of these systems, and it's not coordinated as well as it could be, and so they're bouncing between them, and that gets really costly. It gets costly in terms of man hours. It gets costly in terms of you start a process and you go down a path and they jump to another system and you start over. So the effort is on that smaller collective component that overlaps, those that are struggling with in our community for efficiencies and effectiveness. So, WSU found from all the data and all the conversations, we do have a perfect storm in our community, but our community is not unique. This is a nationwide issue. Behavioral health issues are just monumental in society in general, but as the issues have become more prevalent, the funding has decreased. So there's not a lot of funding going into what everybody talks about as a major societal event. So what they found is absolutely true. Every report, everything you read, everything you hear says that. And so we talked about this in the previous presentation, but mental health intersects every other aspect of public service work. So law enforcement, it also private, the emergency rooms, they're inundated. I mean, there's a backlog in the EDs almost every day with people who are presenting with some sort of a behavioral health issue. Emergency responders, you heard 30% for law enforcement and EMS, 30 to 40%. And so it's just taking a lot of effort and a lot of costly effort. So if we can find community solutions, they're not going to go to the jail as often. They're not going to go to the emergency rooms or need inpatient stays. We have to transport them when we get them up to the state hospital. We don't have a state hospital local. We don't have regional beds. So what? We got to get them into a vehicle and transport them, and nobody transports for free. And I heard the comment that the state solutions, I will say, regional beds we continue to fight for. I think there's a chance this year we'll have some movement on that. There's funding there. It's just a matter of finding those beds to add to our community. So we do have a lot of stopgap efforts. I mean, our community hasn't sat stagnant. We've done a lot of things that are best practice. We've trailblazed, I don't know what I did. We trailblazed a lot of pilot programs, and a lot of them have become permanent, but we have the mental health unit that was put in to the jail, in 2015? 16. Okay, so a lot of these things occurred around similar times, but we have the Community Crisis Center. We've had crisis services for forever in our community, but not to the degree that we have now, that we grew those services in 2015. We have a municipal and drug court. We have a mental health court locally, and we are only one of two areas in our state that have an assisted outpatient treatment court, which is intended for the population we talked previously about, as well as the high utilizers here. These are the people that really struggle. If you have a hospitalization and then you get a 30-day court order to stay connected with services, 30 days isn't enough for somebody that doesn't even recognize that they have a mental health condition or need for treatment for their substance use disorder, or who is homeless. The assisted outpatient treatment court allows us to follow those individuals for up to a year. So it provides them much more opportunity to have success and sustainable solutions than what we have now. And then we talked about ICT-1. So lots going on and lots of effort. It's just not enough. So the two studies, and I hope that you guys have all had access to them. We've made them available on the internet as well as at different meetings, but Ascension obtained a grant, and Catalyst is a group out of North Carolina that came in and looked at what is our behavioral health, what do we have currently in our community, and what would we potentially need in 4 to 5 to 10 years. And as you can imagine, there's going to be some significant gaps. The biggest gap is going to be workforce. But also we have not enough beds in our community for people who are at different stages of their condition. And then the high utilizers really did prove what we knew it would prove. But we have a percentage of our population that just don't stick with a certain provider or a certain organization, and we need to find creative solutions to reduce the burden of that population on our limited resources here in the community. So some of the priorities that WSU and Rothner and Bradley found from conversations and different stakeholder meetings is facilitating access, having more access points, and more importantly, making sure there's handoffs with those access, finding ways to develop new solutions, and then we're going to have to get really creative in finding new ways to fund these innovative services and processes that take place. So the strategies to try to get there were broken into 3 separate task forces. They're access to care, coordination, communication, and collaboration, and workforce, and I'll work from the bottom up. Workforce really is the fact that just like every other sector of industry in our community, getting good qualified people is really difficult. When you're talking about behavioral health and substance use, you add the obligation of having people with the right educational background, the right degrees, the right licenses. That pool to hire shrinks pretty significantly at that point. You're not talking about general population applying for these positions because we're all credentialed and licensed as provider agencies, and those obligations, as well as who pays for services, be it insurance or other parties, mandate that we have licensed master level clinicians to do therapy or assessments, and that we have bachelor degree staff to provide substance abuse services or case management and wraparound support. So it's a complex issue, and we've got to work with the universities and others to build a different pipeline in our community, or find ways to draw people in from other states into our community, which is pretty darn innovative and robust. So coordination, communication, and collaboration is what it sounds like. It's how do we communicate and collaborate and coordinate services in a better way. So, you might have agency A over here that specializes in this, and agency B and C back here, but they don't necessarily always talk together. And part of those problems is, for some of our agencies, we're limited in terms of, particularly substance abuse. A person has to provide written consent for us to share information with other people. So we do, I saw Karen Powell here earlier, our attorney from the county, so she's going to be part of one of these work groups to help us work through, okay, collectively as a community, what can we not share when we're doing warm handoffs to others. And then access to care is really talking about how do we break down the barriers in our community that prevent people from getting their care they need at the right time. Transportation's a big issue. We all know that people have a hard time getting around our community and getting out of the community if they're going to a service provider outside of the central district. But also other issues, in terms of, again, some of that communication stuff and some policies and some mandates that are unique to different organizations. So how do we start breaking that down? And how do we create a warm handoff system where somebody may present at agency A but really need agency B's services? And how do we connect them without losing them in that transition period? Because that's often what happens. We make a referral to another agency and we hold it to the person to try to make it there. Our population that we're talking about, they live a difficult existence. They're struggling with mental health issues. On top of that, they probably have a substance use issue, and they're just trying to meet their basic needs because their housing is unstable or inadequate. So we need to be better working with each other in terms of getting people there and not just suggesting they get that service. Because we're going to start over. So year 1 through 3, this is the work of a large number of people, but everybody seems to agree that we need to right-size the Community Crisis Center. We're at capacity at this point. The capacity exceeds what we have, but in addition to that, we kind of are a gatekeeper to other services in the community. So the goal is to, at some point, craft in the next 1 to 3 years, how can the Community Crisis Center serve as a virtual access point? And since we're not going to build a structure where everybody's working in the same area, how do we create that virtually and know what's going on in the community and other provider agencies and get those resources to people right away? Shared data, it's hard to work and with your high utilizers if you don't know who those high utilizers are. I know the sheriff has a population that he knows is high utilizers. I'm assuming my population overlaps that quite significantly, but we don't know that because we can't share that data very easily at this point. And so finding ways that we can, as a community, build a collective data point for working with this population. Transportation, we spoke to that. We don't have sufficient emergency housing when somebody is in an emotional crisis or a substance use crisis. And then, again, how do we start building that pipeline in year 1 to 3? Because if we don't start building that now, in another year, 2 years, we're going to be in a real critical point in terms of being able to effectively deliver services. And that's going to increase the risk for every party in this room. It's going to result in more need for housing for people who get arrested. It's going to result in potentially more injuries to staff because you don't have the staffing to support the crises that are going on. It's going to result in more law enforcement picking up that burden in the community. You name it. It's going to continue to escalate that crisis. So Again, we're taking a very high-level view because the rollout of the strategic plan in a more formal manner is going to occur at the next summit scheduled for February 27th, starting at 9 a.m., located this time at the Sedgwick County Extension Service. That will also be the first point of our opportunity for the different task force to actually get to know one another and start planning meetings going forward. Once that occurs, we'll have regular ongoing meetings of these task force with the task forces reporting back to the board of directors of the coalition on a monthly basis, and us finding creative ways then to communicate information ongoing back out to the community. And then we also know that we need to define what our desired outcomes are. I think we all know we want people to get the services they need at the time and point where they seek them, and we want to reduce the number of detention stays and law enforcement calls related to behavioral health, but we need to figure out what are those incremental outcomes that we need to achieve to get to those ultimate outcomes. And just like the other pilot we just talked about before, we recognize this is a work in progress. We're going to continue to evolve. We're going to course correct. Where we are today may not be where we go tomorrow, but because we have to be creative. And whatever we do, this is going to be the Wichita model based on Wichita need. We're going to use data to drive some of that decision making, and it needs to be patient-centric and collaborative, and we need to connect with work that's already being done in our community. Specifically, we know that Project Wichita has identified mental health or behavioral health as a primary issue. The Community Health Improvement Plan also indicates that behavioral health is a priority issue. So lots of different groups meeting, and I will say our goal when we collaborated was to reduce the number of groups in the community and get everybody together to talk about behavioral health, but I think those numbers are just bustling still. So with that, the sheriff and I stand for any questions you may have.
So, first of all, thank you, and it's like to recognize and offer the floor to our two members who I believe sit on this task force, which is County Commissioner Lacey Cruz and Vice Mayor Claycomb. If you guys would like the floor, then.
Yeah, I just want to say thank you so much for the hard work that you guys continue to do on a day-to-day basis. I mean, I jumped in, when I was elected, one thing that I talked about even before when I ran was mental health awareness, and it affects everybody. And so first of all, I just can't thank you guys enough for all the work that you've done and the information that you've shared with me. If I could just break this down really, really fast, it's about making the front door easy to find. I think that people who struggle just don't know where to go, or they don't have the access, or they don't have the guts to tell somebody that they need help, plus they're addicted to whatever they're addicted to. So I think that that's mainly, in my mind, it's making the front door easy to find. The stress of this work is unreal for all of us, but what we're doing right now is we are changing the course of Sedgwick County. Like, this is hard stuff that we're dealing with, that we're talking about, but all of us together, we really are changing the course of this county. I am continually impressed with organizations like Humankind and Open Door and Union Rescue Mission. I'm really excited about the possibility of the collaboration of those groups. And there are so many that I didn't mention, but I just want everybody to understand that this is such a collaborative effort, and everybody has to check their egos at the door. This is not about any one individual person, organization. This is about a community coming together to figure out where exactly we can help people in their greatest need. If we could have, for lack of a better word, the Taj Mahal of a community crisis center, if we could put it in one location, if we could collaborate our services, what would that look like? We just spent a ton of money talking about a performing arts center. there's a big uproar in our community about the Riverfront Legacy Master Plan, when in my mind, this is way more important. When we talk about the health of our community, it means the most vulnerable. And so for us to be able to drop on a map what that would look like, I think that we should start spending some time taking that to the next step. Where would this be? So with that, I thank you for having this meeting today and for all of us sitting in the same room. It's about public and private partnerships. And so utilize your resources, ask your people, get on the horn and ask those in this community who have the funding ability to help us make this happen. Because what happened in San Antonio was there was Valero Oil. They ponied up $20 million to get this started. Who in this community can give us 20 million bucks? What could we do with that? So that's my challenge to everybody here. We talk about funding campaigns and funding all these different avenues in our community. Let's use our resources and figure out who we can get to fund mental health and substance abuse efforts and homelessness in our community. So thank you guys so much. I appreciate the time.
Vice Mayor Claycomb.
I don't have much to add, but just a couple of things. I also want to thank you for taking this on. I know it is a big project, and I really appreciate that. You know, when I came on council, I discovered that homelessness is something I deal with every day. I work on a lot of projects. This one is one that I see every day, and what I found was mental health and substance abuse are manifesting themselves in homelessness, particularly in the district I represent. And I tell folks that you can be compassionate for your neighbors, or you can be concerned about the economic development of our community, and both of those are affected by this. And I think so it is a really important issue. I have been absolutely impressed with the work that's been done on this and look forward to continuing the work of the steering committee. Thank you.
Are there any pressing questions? Councilmember Bubag.
Thank you very much, Mayor. And thank you, Sheriff, and thank you guys both for everything you're doing. I'm just looking, is there any more data trying to better understand the root cause? Have we got subgroups that, is it unemployed? Is it veterans? Is it teens? Is it folks with disabilities? Are we doing anything to better understand? We see more of it in this group and that group, and looking for potential solutions so that we don't get into these situations.
I don't know that we have an ongoing data collection project, but I know when we looked at the high utilizers, the things that stood out is that they had underlying mental health issues, and in addition to that, they started using substances, and then ultimately they wound up with unstable housing. So I think there's lots of data out there for us to use, but we haven't really gotten there because we're just now starting to get into the weeds with the task forces.
Okay.
Unless you have something to add.
Yeah, I'd add to that real quick. So by working on this for 3 years now, the entity that's been working on it and the different studies that have been done, it's all the above that you just mentioned. So the VA, we'll take the VA and veterans specifically. We know we have a lot of veterans with these particular issues. The Veterans Administration is now part of this summit and is going to be part of these task forces to help address what we can do with veteran specific, because there's a lot of money that the Veterans Associate or the Veterans Administration can put forth to this, but they need the help in identifying these folks instead of being in jail and the other things that happen to them. So as Joan has said, I think that we will really start identifying the different subgroups that are most affected by this, and we will start looking at plans on how to address those particular subgroups.
Thank you very much.
Further questions? See none. We'd like to, of course,
Just
floor is
mention
yours.
one more time, the summit next week is February 27th. It's at the 4-H Extension building between 9 and 11. As before, you're all invited to come. Some of you are on the task forces, but you're all invited to come for the full rollout of what the strategic plan calls for. So thank you again for allowing us to speak today.
Al, are you winking at me, or do you need a question?
I just want to make a point.
Of course.
I think we need to make a motion to receive and file at some point. I don't want to miss the opportunity to make sure we make that motion. That's all I want to say.
Is that suggestion and a
I would
motion?
make a motion, we receive and file both of these reports.
I would second the motion. Is there discussion on the motion? Seeing none, all in favor of said motion, please say aye.
Aye.
Against, same sign. Seeing none, the motion does pass. Thank you. And thanks for reminding us. It would be terrible if we adjourned and we didn't actually do that. Is there any more discussion on either of the topics? If not, it would be in order for a motion to adjourn.
Motion.
Motion to adjourn? Yep.
Motion comes from Commissioner Cruz, who's quicker than the other chairman, and I will second it. The motion has been made and seconded. All in favor, please say aye.
Aye.
All against, same sign. The ayes have it. The first e-bank meeting of the city and county is now adjourned. Thank you.
I was actually.